Measurement of the dose of radiation, like in any other treatment, is imperative in radiotherapy also. So the radiation absorption dose, mentioned in the terms of Gray, is a unit to measure the amount of energy absorbed per unit mass of the tissue. So 1 Gray is equivalent to 1 joule per kilogram of the tissue, which is equivalent to 100 rats. Currently, the term centigrade, or represented as CGY, is used, and 1 centigrade is equivalent to 1 rad. The amount of radiation the patient receives is calculated by dosimetry. Now we're coming to the individual organs and radiotherapy in them. First, we'll deal with cervical cancer, which is one of the most radiosensitive tumor in the genital tract and has a high chance for cure with radiation. And it has got a curative role in almost all the stages, right from stage 1 to 4. And treatment, however, must be individualized. Multidisciplinary approach with gynecologist, radiotherapist, and pathologist is useful. So for early stage 1A and 1B, for medically inoperable patients and those who refuse surgery, then radiotherapy can be used. And for locally advanced cancer of 1B2, 2B, 3, 4A, concurrent chemoradiation is advisable. An external radiation therapy is delivered by using a 4-field box technique to the pelvis in a dose of 50 Gray in 25 fractions, 5 fractions per week over a period of 5 weeks. So cancer of the uterine cervix, early stage cancer. These are the various methods which are used. We are not going to go into detail of this. And in cancer cervix, in bulky and advanced cancer stage 1B2 to 4A, concurrent chemoradiation is the treatment to be given. And external beam radiotherapy 45 to 50 Gray plus 1 conformal radiotherapy of 40 to 45 Grays to point A. It is total dose of 85 to 90 Gray to point A. And weekly cisplatin 40 mg per square meter. 6 doses or 3 weekly cisplatin plus 5 fluorouracil twice to be repeated. And 5-year survivals are reported to be quite high in stage 1, that is 80 to 85%. In stage 1B2 to A it is 72. In stage 2B it is 70 to 80%. Stage 3B it's 50%, and stage 4 it's 15 to 20%. So in brachytherapy there are various methods can be employed, which is known as the Stockholm system, Paris system, and Manchester system. Details we'll be dealing in next few slides. So in the Stockholm system there is a flexible tube which is introduced, and there is a flat box or plate kept in the vagina. This is the Paris system which is being used, and this is a diagrammatic representation of the Manchester system. Again, those points of point A and point B have been taken into consideration over here, and so this is then the comparison between the various systems. In the Paris technique, there is one intrauterine tube, and then there is 2 vaginal ovoids, and one application is done to the duration of 5 to 7 days. And in the Stockholm technique, it is an intrauterine tube of 50 mg and vaginal box which contains 50 to 60 mg, and 3 applications are to be used. And in the Manchester technique, it is this thing 35 to 40 mg of intrauterine tube and vaginal voids. This thing of 20 to 22.5 mg are used, and 2 applications are advocated. So treatment overview of cancer cervix as far as radiotherapy is concerned, and other modalities. It is in early stage, it is surgery and radiotherapy are equally viable options, and treatment decision is based on factors such as age, menopausal status, and concurrent medical illness. Generally, radical surgery is chosen for younger women who do not desire cessation of their ovarian function or alteration in their sexual function, which would usually follow the radiotherapy. So this way in younger women, in early stages, usually the surgery is preferred over radiotherapy. And a few words about postoperative radiation therapy in cervical cancer. It has demonstrated increased local control for those patients with at least two of the following features. That is, if there is more than 1/3 of stromal invasion, and if the tumor is bulky, or there is presence of lymphovascular invasion. So in endometrial cancer, usually the hysterectomy is the first choice. However, if hysterectomy is medically contraindicated, primary radiotherapy can offer 5-year disease-specific survival rates of 80 to 90%. An indication of adjuvant radiation after surgery for endometrial cancer are somewhat controversial. And whole pelvis external beam radiotherapy and intravaginal brachytherapy are potential adjuvant postoperative therapies for patients with stage 1 disease. And the recommendations are usually based on the stage of the cancer and the grade of the disease, depending upon the histopathology report. So in endometrial cancer, adjuvant radiotherapy, postoperative adjuvant radiotherapy may be considered depending on surgical and pathological factors. And radical radiotherapy can be used as standard treatment for patients with stage 3 endometrial cancer and for those with early stage disease in whom surgery is contraindicated. So teletherapy in external beam doses prescribed to intersection points of radiation beams are 40 gray in 20 fractions over 4 weeks or 45 gray in 45 fractions over 5 weeks. And there is no consensus on dose specification points in uterine cancer, unlike that of the cervical cancer where it is fixed. So vulvar cancer, most common malignant lesion is squamous cell carcinoma, and usually the radiotherapy is not the first choice over here. And the aim of integrated multimodal therapy is to reduce the risk of local regional failure in patients with advanced primary or distant node involvement. And like I told earlier, response to radiation is poor due to intolerance of the moist region to radiation and poor vascularity of the vulva. So the radical vulvectomy with bilateral block dissection of the nodes is usually the first preferred treatment of choice. And among the radiotherapy, electron beam therapy is superior than others. In vaginal cancer, and a primary non-surgical treatment is usually preferable for stage 1 or stage 2 vaginal lesions. Partial or total vaginectomy followed by postoperative radiotherapy is sometimes feasible for these cases. So combined treatment with radiotherapy and cisplatin is likely to be more beneficial than radiotherapy alone. And external beam radiotherapy is administered to fields in doses of 45 to 50 gray, and tailored interstitial brachytherapy is generally necessary to deliver potentially curative doses of radiation to the primary site. So in ovarian cancer, traditionally earlier whole pelvic radiotherapy alone was offered, but nowadays it is not being done because we have got much better chemotherapeutic agents. And postoperative pelvic chemoradiation is recommended for patients with cancers of stage 1B1 or higher that are incidentally found after simple hysterectomy for presumed benign disease. So one of the of radiotherapy, use of radiotherapy in ovarian cancer is that of the palliative radiotherapy. It's frequently offered to patients who have focally symptomatic recurrences of ovarian cancer, and for patients with painful or hemorrhagic pelvic masses refractory to chemotherapy, a hypofractionated schedule may be considered and then repeated at 2 to 4 weekly intervals. 3 monthly fractions of 10 gray are also reasonable, especially in patients with poor performance and a limited life expectancy, in whom convenience and expediency are paramount. So recently, however, there has been a renewed interest in assessing the feasibility of advanced radiotherapy like intensity modulated radiotherapy with tumor-therapy in ovarian cancer. There is also an emerging option of stereotactic ablative radiation, that is SABR, for isolated relapses of ovarian cancer. What about radiotherapy in choriocarcinoma? Though the choriocarcinoma is radiosensitive, radiotherapy is usually not used in the management as chemotherapy is highly effective. Our radiation is reserved for metastasis to CNS, spinal cord, or liver. So, as of any treatment modality, quality assurance and treatment delivery is important. So, calculated dose for radiotherapy needs to be verified repeatedly with the actual dose delivered on the treatment unit, and this involves a complex process of physics and dosimetry. So the position of the patient is verified by a variety of systems, and in the modern systems it is quite complicated, and the patient position verification has to be frequently repeated during the radiotherapy. So as with other treatment modalities, the radiation also has got several reactions, and systemic and local reactions depend on the volume of the area treated, the dose delivered, and the tolerance of tissues. Systemic reactions like nausea, vomiting, anorexia, lassitude, fever, and convulsions can occur, and most of these symptoms can be controlled by antiemetics and antihistaminics. So nausea and vomiting associated with diarrhea is usually treated by correction of electrolyte imbalances, and if necessary IV fluids are given. Leukopenia and thrombocytopenia, the treatment is hematinics or blood transfusion, and these have to be repeated during the post-radiation period. Intestinal reaction usually are treated by antispasmodic, analgesics, and antidiarrheals as per the symptoms. So the bladder symptoms, the treatment is liberal fluid intake, potassium citrate, and urinary analgesic. Skin reaction usually is for the peeling on wet areas. So 1% aqueous gential violet is the recommended treatment, and the area has to be kept dry with talcum powder. And in some cases, the subcutaneous fibrosis may result. Severe intestinal reactions are likely if pre-existing adhesions are present in the abdominal cavity. The reactions can be very severe in form of gangrene of the intestine and sometimes intestinal obstruction. Mild proctitis and cystitis are treated with which occur with the intracavitary radiation, and again the symptomatic treatment is given in them. Late sequelae like wall stenosis and vaginal fibrosis usually should not occur, then they are easily preventable if proper method of radiotherapy is used. So advances in radiation therapy, higher linear energy transfers like X-rays and gamma rays are less effective against hypoxic cells compared to oxygenated cells. So that's why higher linear energy transfer has to be given. Fast neutrons or negative pi mesons, that is pions, or protons are very effective against hypoxic cells. So fast neutron beam for radiotherapy are generated by the cyclotron and the deuterium tritium generator. And negative pi mesons, pions have a high biologic effectiveness and a low dependence of oxygen. So in hypoxic cells, this is the method of treatment which is nowadays being used. So a few words about the radiopotentiators and hypoxic cell sensitizers. This we had dealt briefly in when we were dealing with tissue tolerance. So hypoxic cells usually they require about 3 times the radiation dose. And amongst the various methods, chemotherapeutic agents can be used, and hypoxic cells can be sensitized to ionizing radiation to improve what is called as oxygen enhancement ratio. So the chemotherapeutic agents which can be used for this are cisplatin, paclitaxel, gemcitabine, doxorubicin, metronidazole, interferon, acyclovir, etc. Hyperbaric oxygen, though theoretically it is useful, practically it has not found to be that much useful for hypoxic cell sensitization. Hypothermia has been found to be helpful for these cases. So new technology for radiation therapy, we have already dealt partly earlier. One is the three-dimensional conformal radiation therapy, which uses imaging modalities of CT, MRI and PET scanning for radiation treatment planning. And then accordingly, the radiation is given. Then another one is intensity modulated radiation therapy, which we have already discussed. This method uses the power of computers to shape and perform thousands of iterations of planning. Quite complicated affair. Then there is a stereotactic radiotherapy and gamma knife radiation. This is similar to intensity modulated radiation therapy and 3D conformal radiation therapy to allow more precise localization of beam and verification of the dose delivered. Thank you.